So moving on, we're going to talk about testing cardiorespiratory fitness. This is also known as aerobic fitness. So when we're assessing someone's aerobic fitness or exercise capacity, as it's sometimes called, our criterion measure is VO2 max. So remember, this is just maximal oxygen consumption. This is our best indicator of aerobic fitness. So there's different ways to get this. We can measure it directly via a maximal graded exercise test. And this is where you measure oxygen consumption continuously while someone exercises until they reach their maximal exertion. Sometimes this is called a symptom-limited graded exercise test, especially in clinical situations, because the test is limited by the patient's symptoms. We can also estimate VO2 max via a submaximal graded exercise test, where there's a predetermined stopping point, and we then generally estimate VO2 max based from the extrapolating the heart rate, because we know heart rate is going to continue to go up linearly with intensity. And then we can also estimate VO2 max via field test, which could be either maximal or submaximal. But VO2 max is estimated in field tests by either exercise performance, like maybe a 1.5 mile run. That's a common one depending on how fast you run it. You get an estimated VO2 max, or how the heart rate responds to a given bout. So like something like a step test where you step up and down for 3 minutes and you measure your recovery heart rate, and you can get an estimate of VO2 max based on what how quickly the heart rate recovers. So these are all options for either estimating or measuring VO2 max. So a little comparison between maximal and submaximal test. Good thing about maximal tests, they're very accurate, very sensitive at detecting disease if that's what the purpose of the test is. The negative thing is they're potentially dangerous because the person is exerting themselves to a maximal level. So for a healthy person, this is less of an issue, but for someone with maybe underlying cardiovascular issues, this could be potentially problematic. They also are expensive. They require expensive equipment, also well-trained staff, and it could be rather time-consuming when you factor in all the calibrations and factors going into setting up the test. For submaximal, the good thing is less risky. They're cheaper, less time-consuming, and the trade-off is they're less accurate and less sensitive. As far as modalities of exercise testing for aerobic fitness, do a treadmill. We can do graded, maximal, or submax. We can do the same thing with a cycle ergometer, a maximal test or a submaximal test. Step testing, commonly, like I said, we measure the post-exercise heart rate. Other field tests, walking, running a distance for a period of time, like I said, the 1.5 mile run. There's also a 12-minute run. You see how far you can get in 12 minutes. So as far as graded exercise test protocols, for treadmill, there are established protocols that you can use, or you can design your own. But some of the major ones that you may have heard of before and for treadmill exercise protocols, there's the Bruce protocol, the modified Bruce, the bulky, the not, and I'll talk a little bit about those and show you what they look like. For bike, you can do an individualized protocol. There's a set Ymca submax bike test. That's where you extrapolate heart rate based on how the heart rate responds at different intensities of cycling. As far as if you're going to do a graded exercise test on a bike that's going to reach maximal levels, it's generally recommended that you just design your own. There's not standardized protocols like there are for the treadmill. So usually what this entails is you just kind of design in your own increases in workload every few minutes until the person can't continue. So as far as field tests, like I said, the 1 mile walk, 1.5 mile run, 12-minute run, 6-minute walk test. Step test, there's a Queen's College test, which is a 3-minute test where you measure recovery heart rate. So when choosing or designing one of these protocols, you want to consider what the person can do. If they have limitations where they can't run on a treadmill, you may want to do a walking protocol on a treadmill, or maybe switch to a bike or some other modality. The other thing to consider is cost. What do you have access to? So if you have access to a laboratory, obviously you would want to do a VO2 max test on a bike or a treadmill. Whereas if you don't have access to that, you could always do a submaximal test if you have access to even just a bike, or some type of field test or step test. So this is the standard Bruce protocol that is done on a treadmill. This is probably the most popular protocol done, and it's probably the most famous protocol. But you can see the speed starts out at walking, 3-minute stages, and it's very intense because the incline is very steep, and the intensity changes every 3 minutes until the person can't go anymore. Most people are going to, even healthy adults, are going to fatigue somewhere in here once you get to that 4.2 or the 5 miles an hour. So for the modified Bruce, very similar, except it has a couple of initial stages to get the subject more in line, or get them kind of almost like a warm-up period to get them moving before they jump into this first stage. So you can see the first few stages are not at that 10% incline, so 0 and then 5%, and then they jump into the traditional Bruce protocol. The bulky protocol, standard speed, 3.3 miles an hour, which is a brisk walk for most people, and then every minute it increases in grade. Other treadmill protocols, not in 2 to 3 miles an hour, either or, and then grade increases every 2 minutes. So another walking protocol. You can also do your own ramp protocol, which a ramp protocol just means that there's very frequent small increases in intensity. So for examples, a 1% every 30 seconds or a 0.5% every 15 seconds. So it's a more gradual thing. Instead of having these big abrupt changes every 2 to 3 minutes, you just get a more frequent, smaller changes in intensity. So as far as, like I said, on a bike, there are not standard protocols like there are for the treadmill. So you don't generally design your own. So examples, what you could do, 25 watts every 2 to 3 minutes. I've used that multiple times. Usually every 2 minutes makes it go a little bit quicker, maybe starting at 100 watts. Or you could do some version of a ramp protocol where you're just increasing 1 watt every few seconds. So it just makes it like a more smoother increase in intensity. Here's the Ymca submaximal bike test that I was alluding to. So you can see that however fit you are, you're going to stop at the 4th stage. And then based on the heart rate responses to those first 4 stages, you extrapolate and get an estimate of your maximal workload, which then you can estimate your VO2 max based on that. So the way this works, everyone starts at 50 RPMs, which is really slow for most people, at 0.5 kg. And then depending on the heart rate at the end of the first stage, they follow one of these columns down for the next 3 stages. And you just measure heart rate and plot it out after and extrapolate to get an estimated max workload. So measurements you would take during an exercise test, there's the big 3, or I should actually call it the big 4, that no matter what situation you're in, you should always assess. So that would be heart rate, blood pressure, and something called RPE, rating of perceived exertion. And I like the 6 to 20 scale, which I'll show you. And the 4th one that's not up here, that seems like a no-brainer, but I should mention it, is just monitoring the patient's signs and symptoms. So you always want to make sure you're monitoring the patient, or I should say client or participant if it's not in a clinical situation, just to make sure that they're doing okay and they don't have any overt signs or symptoms that might indicate that this test needs to stop. So other options that you can add on, especially if it's a clinical population, EKG. If you're doing a maximal test where you may want to measure oxygen consumption, so VO2, VCO2, ventilation, some RER you've heard of. So there's also subjective scales for chest pain. So there's an Angina Scale for breathing, dyspnea scale, a Claudication scale, and O2 saturation. All of those are just specific to the population being tested. For example, if you're doing an exercise test in a pulmonary patient, you would definitely want to measure oxygen saturation just to make sure there's no desaturation during exercise. And also probably the dyspnea scale to see how out of breath they were. So here's the RPE scale I was talking about. So this is the one that is used more in research and for exercise testing. It's a 6 to 20 scale, 6 no exertion, 20 maximal exertion, where the participant will rate how they're feeling at each stage. And then you can also use a 0 to 10 scale, which a lot of people can relate more so to the 0 to 10 scale, but for exercise testing purposes, I lean more to this side because it correlates a lot better with heart rate. Because if you think about really the way this was designed is that if you put a 0 behind each of these numbers, it kind of gives you an idea of where the heart rate might be. So assuming that you have a resting heart rate of 60 and a max of 200, it gives you a rough idea of where the person might be, although it's not 100% foolproof. All right, so other subjective scales that might be there, that you might be using, Angina Scale, you can see it's 1 to 4. And this, again, these are only if needed. The Dyspnea Scale, 1 to 4. And then as far as terminating the test, there are certain criteria that if they come up during the test that you should stop. And the criteria here, this is for low-risk adults, meaning just a healthy adult, not a clinical patient. So if any of these things occur, you should stop the exercise test immediately. So onset of angina or an angina-like symptom, so just chest pain out of nowhere, significant drop in blood pressure. So, and this is referring to mainly systolic blood pressure. So we know systolic should go up linearly, and if it's not, and if it's dropping, that's a huge red flag. Alternatively, if you got an excessive rise in blood pressure to 250 over 115 systolic diastolic, that would be rationale to stop. Shortness of breath, leg cramps, or claudication. So everybody's going to be breathing heavily during intense exercise, but you can usually tell if somebody's really, really short of breath, and that's what it's talking about here. So other signs of poor perfusion like lightheadedness, confusion, if someone just doesn't look right, that's a good indication to stop. Failure of heart rate to increase with intensity, change in heart rhythm, that would only be really noticeable if you were monitoring an EKG. Subject asked to stop, obviously, that would be a reason to stop. Any physical or verbal manifestations of fatigue, that kind of plays into this one about the signs that someone might be showing. And then any failure of the testing equipment, whether that be blood pressure monitor, heart rate monitor, treadmill, etc. So general procedures for conducting an exercise test. So before the test, you want to decide on a protocol, assess some baseline measurements in the supine and exercise position. So treadmill test, also while they're standing, if it's a bike test, while they're sitting on the bike. So blood pressure, heart rate, EKG if you're measuring it. Explain the test to the subject, explain the modality, like if there's a bike, make sure the seat's the right height, the handlebars are in the right place. The Rpe scale, make sure they understand it. That's key, because a lot of people have not seen that 6 to 20 Rpe scale before. And tell them you're going to be asking them for a number every so often. Any other pre-test instructions, such as we're going to be assessing your blood pressure every stage or every few minutes. We're going to be collecting your heart rate every minute, RPE every stage, and anything else that you might be doing during that test, and that the workload will increase every few minutes. Some baseline gas exchange, so like oxygen consumption at baseline, and then a light warm-up. During the test, these are important measurements, so definitely heart rate every minute, blood pressure at least one time per stage, RPE at least each stage. If I personally like to do it every minute because it's an easy number to get, especially as subjects or participants get more towards their max, the RPE may change within a stage. So also EKG, if you're measuring it, you measure it continuously and then record it, save it at least every stage. Continuously collect the gases and ventilation. Signs, symptoms, monitor continuously, and then subjective scales as necessary, like the angina or the dyspnea scale. Then after the test, active cool down. Usually that's the first workload. So if you started at 100 watts for that first stage, you go back to 100 watts on the bike or treadmill, whatever speed you started at. Usually 2 miles an hour, 3 miles an hour on a flat surface is pretty good. As far as sometimes you might want to do a passive cool down. This would only be if the person cannot do an active cool down, or if you're screening for, the purpose of the test is screening for disease and a physician is present. A lot of times they'll have the participant lie down after the test. It's more likely that you'll see some abnormality on an EKG with a passive cool down. So again, that would only be if that purpose was to screen for disease. And then you want to, during recovery, continue to monitor heart rate, blood pressure, and EKG if you're taking it for at least 5 minutes. And blood pressure, heart rate should return towards baseline levels. They won't reach true baseline levels, but they'll get close. And if there's any signs or abnormal responses, you would extend that period if necessary. So that's a lot about assessing aerobic capacity. In addition to that, we can assess body composition. We've already talked about assessing muscular fitness, but body composition, we talked about BMI, waist circumference, but we can also, if we have access to it, there are other techniques to get a better estimate of body composition. And so as far as circumference measures, we talked about the waist-hip ratio, but you can also do other places on the body. So ideally, if you're doing circumference measures, you would use a Gulick tape measure, which is a spring-loaded tape measure like this. It just controls for the tension that you're putting on it, so you don't pull too tight or too loosely. So the sites that you might want to do this: abdomen, arm, the butt, calf, forearm, hips, mid-thigh, and waist. So there are established landmarks for all of these, and these are in the ACSM book. You really don't need to know exactly where they are, but just be aware that there are specific landmarks for all of these measurements. As far as skinfold measurements, measure skinfold thickness at various sites. You can do 3 sites, 5 sites, 7 sites, and put them in a prediction equation to get an estimate of body fat. So this technique is going to assume that subcutaneous fat is proportional to total body fat. And these are the major sites. And we talked about, again, you don't have to be familiar with these sites, but there are exact landmarks. If you want to look in the ACSM book, it's there. So how accurate are they? For skin folds, most research will say about 3.5%, and that's assuming that the technician doing it is pretty competent. So if the person doing the skin folds is not very good at it, that's the biggest chance of error. So it's something that a tester will learn with a lot of practice. So other techniques for body composition: Dexa, where you take an x-ray scan of the body, can distinguish between fat, bone, other tissue. Really expensive, but the error is the lowest. So this is considered by most to be the most accurate way to assess percent body fat and or estimate percent body fat. And underwater weighing, which used to be considered the gold standard for most, also really accurate as an estimate of body composition. So basically you weigh yourself underwater, and it gives an indication of body volume, which can allow you to assess body density. So based on Archimedes' principle, which basically says that if you're underwater, you'll be pushed up by a force that's equal to your volume. And the volume is important here because if you know your mass and you know your volume, you can calculate your body density. Once you get your body density, you can get a good estimate of percent body fat. So as far as other techniques, air displacement plethysmography, something called the bod pod, which looks like this. The concept is it measures how much air your body displaces. And in return, if you know that, you can, again, estimate body density, because you can measure the mass, body mass with a scale, and then you have the volume, and then you can get body density. So lastly, bioelectrical impedance, where small electric currents pass through the body, and basically the more resistance to flow, that means less body fat. So it's based on the assumption that fat-free mass is a better conductor of electricity than fat is. So sources of error increase a little bit with this technique, but there are different grades of bioelectrical impedance. This is something called the Ymca scale, which is more of a research grade bioelectrical impedance. Here's more of a research grade bioelectrical impedance. In-body is something you might see in some health clubs. Works via the same technique. And then something that's really low cost might be something like this, where you just hold it in your hands and it gives you a number.